So in your states in California, you have a tattoo, right? You're
It's Lunar New Year, but I don't think we don't start it until next. I think it's January 25th is the start of the Lunar New Year, right?
yeah, 21st, so 3 days more.
Yeah, so in a little bit. Yeah, next week. I think next week's the start of Tet for us. But everyone's already starting to celebrate, it sounds like.
Right. In Vietnam, we celebrate it before a month, 4 weeks before
It's for a
that.
whole month,
Right.
4 weeks.
Yeah, so we buy something, we buy flour, we buy
Yeah.
food, and we go to together to closing the year party. So Vietnamese
Hmm.
often celebrate the year party with the Lunar New Year, not the like first day of the year, no, but Lunar New
Yeah.
Year. So before a month, so we can gathering everybody, just like my department or other department. So they just gathering and to celebrate that. Okay, 2022, what happened and what we have, and we year parties, and until now, so we have more 3 more days until the Lunar New Year Eve. So this is the in Vietnam we the cat year, not the rabbit. It's different.
Oh, it's cat. It's cat. Oh,
Yeah,
it's a
yeah.
different one. I didn't know that.
Really, you don't know that, right? In Vietnam,
I didn't.
we are cat year, not rabbit year. Cat, right? A little cat.
I'm
Mm-hmm.
I'm looking up right now the Vietnamese zodiac. So there's rat, buffalo, tiger, cat,
Yeah.
dragon.
Mm-hmm.
Oh, there's a cat. What is the? Oh, interesting.
So it's the same with Chinese, but we change the rabbit to the cat.
Oh, interesting.
All right. So for a long year before that, so maybe when you pronounce it, maybe the rabbit and the cat in Chinese is so so close. So Vietnamese many years before that they say that the rabbit, but we think that it's the cat. So the K before that we just celebrate the
Hmm.
cat. So the tail zodiac is the same but different for the cat to the rabbit. So in Chinese, in
Yeah.
Hong Kong, in Taiwan, all the rabbit,
Yeah.
but in Vietnam we have the cat. It's different, right?
That's very that's very interesting. I just learned this. That's very interesting.
Mm-hmm. Right. Okay, so let's start. It's night.
You want to get started?
Yeah.
Is anyone else gonna come? Do you think?
All right. They will come. Don't worry about them. Just go. We
should
have
I
a
po- should I post should I post it in the chat really quick?
oh,
Do you think or
okay. So you post something on the chat board on
yeah? Let me
WhatsApp.
post it in the chat right now, and then
All
we'll
right.
get started.
All right.
Just give me 1 second. I'm gonna post our.
Hello, Thảo. Okay.
Okay, I just posted
All right.
that there. Hopefully, let me see.
Okay. There we go. We have 6 attendees right now.
Few
So,
more people are joining. Perfect. Okay, let me get everything set up in just 1 second first. Hold on 1 second. Oh, great. Okay, we're getting some people here. Let me just share the screen. Okay. Just message. Okay. Everyone can hear me okay? So, this is our last session before the New Year. And we'll be talking about foreign bodies and geriatric abdominal pain today. So foreign bodies are basically anything that basically shouldn't be inside your esophagus or inside your intestine that's there now. So we have a number of things, right? So for kids, some of the most common things include like coins or toys or batteries. They're all very common foreign bodies for kids. And in adults, food bowls can be very common, either like meat or fish bones or something that adults can swallow, or other objects. People sometimes, accidentally choke on kind of like small objects. I mean, those can all be kind of foreign bodies there. One of the things we want to be aware of the most is if there is any kind of obstruction, which means kind of like blocking the entire esophagus or the trachea. And so, like the cricopharyngeus muscle is the most at the level of C6. That is the most common place for like a foreign body to get stuck. Some of the other places where it can get stuck include the esophagus, where the aorta kind of crosses over the esophagus and puts some pressure on there. The lower esophageal sphincter right before we get into the stomach. And if a foreign body passes the pylorus, it's likely going to continue passing on without any further complications. And so objects that are greater than 2 to 2.5 centimeters wide, greater than 6 centimeters long, or any objects with sharp or other kind of irregular edges, those are less likely to pass through on its own and more likely to cause an injury on its way out. So when you're doing a history and an exam, this includes checking the airway. That's the most important part, ensuring that the airway is patent and that patients are able to breathe. You want to ensure that to see if they're swallowing and able to tolerate their secretions. If they're able to swallow and drink water and they're not drooling, it's unlikely to be a complete obstruction of the esophagus or the trachea. You want to look for any choking episodes. If they have a history of choking, at a restaurant or while they were eating, or if they turn blue or cyanotic. And you want to see if they have a history of dysphagia or odynophagia, any painful swallowing or difficulty swallowing. So some of the imaging. A chest X-ray is the most common for foreign body, and usually we get a PA and lateral view. If you're concerned about a foreign body and you don't see anything on the chest X-ray, you can also get a CT scan of the chest, which is very sensitive for radio-opaque and non-radio-opaque foreign bodies. So like foreign bodies that we can see on X-ray and things that we don't see. The chest CT is a lot more sensitive for that. And we can also so the endoscopy by GI, basically putting in a camera down the throat and into the esophagus to look around, that is kind of considered the gold standard for diagnosis and management. So radio-opaque bodies, so like foreign bodies that we can see on X-ray, those include metallic objects such as aluminum, animal bones, sometimes kind of depends on the type of bone, and glass. Those all tend to be radio-opaque foreign bodies. Things that are radiolucent, that includes plastic, wood, any kind of plant thorns or splinters. Fish bones are generally not seen very well, as well as most kind of food objects are not seen very well on an X-ray. So you basically want to figure out if something is radiopaque or radiolucent. And one way you can actually do is sometimes when kids come in with a swallowed foreign body, sometimes parents will bring in the other object as well. They'll say like, oh, they swallowed this, they swallowed this toy, and here's another one just like it. What you can do is shoot an X-ray of that toy that the parent brought in and see if it's something you can see or not. If you can see on the X-ray, then you can shoot an X-ray of the child and see if you see that object inside of them. And that way it offers a good kind of comparison of how to take a look at everything. So what does this look like? So this is a foreign body, right? We see a foreign body inside a child here. Does this look like it's in the esophagus or in the trachea? And does anyone want to, you can answer, or you can put it in the chat. Yeah, so this was a coin, actually. They have a coin here. But do we think it's in the esophagus or the trachea? Like, where is this right now? Yeah, correct. This is the esophagus, right? So there's one easy way to tell if it's in the esophagus or the trachea. If you see here, let me see if I can mark this up. What you can just, if you see over here, so when you shoot a PA lateral, if you see the kind of the face of the coin, if you see the entire wide side of the coin, this is more likely to be in the esophagus right here. And I'll shoot an example of the next one. Like something like this right here, where you see the coin and you see the very thin face of it, this tends to be considered to be inside the trachea. So I'll show the two one more time. This one right here is in the esophagus. And then this one right here is more likely to be in the trachea. And you can see that there's a, if you see right here, this part has the nice wide kind of face going on. And then when we switch over to here, we see that it's in a very narrow type of face right here. This is very narrow. So this is how we can tell if it's in the trachea or if it's in the esophagus. So this right here, anyone know what this one is? So we saw a coin earlier, right? This right here was the coin right here, where it's kind of, it's nice and symmetric in one color. This object right here, we see has, this object right here, we see has two rings, one outer ring and one inner ring. Any idea what this could be? You can answer in the chat or if you want to, or on the video call. Any ideas what this would be? Close. Yeah, this is a button battery. So this is a special kind of battery that is found, I'll put it in the chat, a button battery. So this is a special kind of like flat battery that's found in a lot of toys for kids. And it's very often that they kind of swallow these objects. And so, especially when you find a button battery, and we'll talk a little bit more, but these are pretty high risk objects for kids to swallow. And we'll talk about that in a little bit more. This right here, this is another good way to see if a child has swallowed a foreign body or not. And so has anyone ever done lateral decubitus x-rays before for a child? This is basically, like, for example, if you're concerned about a kid may have swallowed a foreign body and it's in one of the bronchi, in either the left or the right main stem bronchi, and causing obstruction to the lung, you can obtain these x-rays called left lateral decubitus x-rays. And what happens is, what you do is you put the child on the left side and you basically, you do a left, you put them on the left side, you take an x-ray, you put them on the right side, you take an x-ray as well. And what happens is, normally the air will, like normally when you have a patient in left lateral decubitus, the air kind of goes to the top, right? It's hyperinflated at the top and hypoinflated at the bottom. However, if there's an object here inside the lung that's blocking the release of air because it's inside the trachea, what you can get hyperinflation of the lung that's closer to gravity. So the lower lung, which normally has less air, if there's an object stuck there, the air can't get out. And you can sometimes see more air here than the top here. And that's one way you can do to kind of see if you have a foreign body inside the lungs. Another way what you can do to, if you see a foreign body in a patient's mouth, another way to go about this is to, you can use a laryngoscope, like something used for intubation, and kind of a pair of alligator forceps. Like forceps are long with a small tip at the end. You can spray the back of their mouth with hurricane spray to kind of numb up the back of the area, and then use those alligator forceps to reach back and pull the foreign body out. So, if you can see the foreign body maybe is right at the base of the tongue or right in the pharynx, and you're not able to reach it by hand, this is a good way also to try to get the foreign bodies out using a laryngoscope, and with alligator forceps and with the hurricane spray. So when do you need an emergent consult for a foreign body? If there is any kind of airway obstruction, where a patient, is not able to breathe on their own, that's definitely an emergent reason why you need to intubate and probably do a bronchoscopy. If the patient is not able to tolerate secretions, they're drooling, they're not able to swallow, those are all reasons that you need an emergent consult as well. If there is a button battery in the esophagus, so like we talked about right here, the button battery right here, if you see this inside the esophagus, that is also a reason that you need an emergent GI consult to take the button battery out, because it can cause a perforation of the esophagus in about 6 hours. And there's a high risk of mercury toxicity. There's a lot of mercury inside those batteries, and that can cause pretty quick toxicity. Any kind of sharp foreign bodies that are great, especially foreign bodies that are greater than 2 centimeters wide and greater than 6 centimeters long. If you have multiple foreign bodies, so they swallow a lot of different objects, those are all reasons for kind of emergent consult. If you have a lot of magnets, so you have a bowel obstruction or a perforation, that can, the multiple magnets can stick together inside the bowel and lead to kind of necrosis there and a perforation. And if you have a coin at the cricopharyngeus level that we talked about C6, if you have a coin stuck there, it's probably not going to pass because that's the narrowest part of the esophagus going down. And that's probably where you'll need to get a consult for an endoscopy as well. So food bolus. There are a couple of things we can sometimes use to treat a food bolus. And that includes and a lot of these are not very evidence-based or not very scientifically based. They're more from experience that doctors have when taking care of patients. But some of those options include, you can do glucagon, 1 to 2 milligrams IV or IM, can sometimes help patients, pass along a food bolus. But you want to be careful because this, trying to vomit up a food bolus can lead to nausea and vomiting. So sometimes you want to give them Zofran as well before. You can try carbonated beverages like soda or club soda or kind of like ginger ale. And this is anecdotal as well. And it can sometimes lead to dilation of the esophagus. You can, for uncomplicated kind of incomplete food bolus, so it's not blocking their airway, it's not, they're not drooling, they're able to swallow and tolerate secretions. That can be managed kind of expectantly as well, for no more than about 12 hours. So if you're going for greater than 12 hours, at that point, you're starting to run the risk of esophageal damage. Sharp objects do require emergent removal, especially if it's in the esophagus, the stomach, or the duodenum. If it's past the duodenum, you can observe the patient very closely for any kind of perforation that's going on. So, for any time you have a sharp object, you want to talk very closely with GI about kind of their next steps and how they want to manage the patient carefully. Any idea what this is? What we see right here? It's not poop, though it looks kind of like poop there. This is intentional ingestion or body packing. So this is someone who has intentionally swallowed a lot of little plastic bags, usually of drugs that people use to try to smuggle, across the border. But this can happen when people are trying to take, drugs across aborted without being detected, they can sometimes swallow a lot of packets, or they can insert a lot of packets up their rectum to carry it inside their body. So there are different kinds of intestinal ingestion, right? There's patients, what we call packers, and these patients ingest packets as a means of transport. So they bring a lot with them, and they're at very high risk of toxicity because they have so many different types of drugs inside their body. If any of the little packets rupture, they're going to definitely absorb all of those drugs, and it can lead to a very high toxicity. There's also what we call stuffers. So stuffers are basically when patients ingest some drug packets in a hurry to avoid kind of being detected by law enforcement. And these patients are more prone to rupture because they either insert it through the rectum or swallow it so quickly. They're at a higher risk of their bowel perforating or an injury there. And pushers are when they kind of insert different foreign bodies into various kind of orifices in the body, either in the mouth or in the ear or up the rectum. And these are usually more intentional and for pleasure that why patients do this. So here is a example of a pretty good algorithm for how to manage, patients who have intentionally kind of ingested foreign bodies, especially if you're concerned about some kind of substance that they ingested. So you want to get an IV, you want them on cardiac monitoring and EKG and lab work. And you want to start with some radiology studies if they're stable. So things like you can do like X-rays of the abdomen or CT scans of the belly to kind of see what may be inside their GI system. If the patient is asymptomatic, they're not having any symptoms at all, you can consider whole bowel irrigation with polyethylene glycol. And you definitely want to observe these patients for at least 24 hours or until all of the packed objects have passed. You want to make sure that there's at least 2 to 3 normal stools, that they're not passing kind of any packets in their stool, and then they have a negative repeated radiology study. So you also want to be really aware if these patients have toxicity. And so toxicity, that could include something like opioid toxicity, if they have a lot of kind of opioids that were inside the little packets that were inside their body. And if that's the case, you want to give them naloxone for reversal of the opioid toxicity and to provide some kind of respiratory support. You also want to be very aware of sympathomimetic toxicity, so things like cocaine or heroin that patients may have kind of inserted inside their body. And if they are showing any signs of sympathomimetic toxicity, we want to go ahead and give them benzodiazepines, and we want to start cooling them, and we want to start them on antihypertensive. And you want to be very aware of any kind of other abdominal complication as well. So if there's any abdominal pain, there's any sense of kind of obstruction where they're vomiting, or any perforation or peritoneal signs, those are all indications for a surgical consultation as well. Any questions so far? Either you can put it in the chat or you can ask them right now, or we'll definitely have some time for questions in the end as well. Keep going. Okay. What is this right here? Any ideas? So this is a retained rectal foreign body, right? So this looks like a spray can that was inserted into the rectum here. So a retained rectal foreign body, again, it's very important to get, history and exam to kind of understand what's going on and why patients are presenting with the rectal foreign body. Again, similar to all other foreign bodies, we want to be aware of any kind of bowel perforation, peritonitis. Some of the most common kind of findings include, vegetables, bottles, light bulbs, toys. You often want to get imaging before performing a rectal exam, like either an X-ray or a CT scan, so that you understand, if there's a sharp object inside there, you don't want to insert your finger blindly into the rectum and risk injury to yourself. So, we generally encourage imaging before any kind of rectal exam. And if there's a surgery, and if there's any kind of bowel perforation or peritoneal signs or abdominal pain, you definitely want to get a surgical consultation for that. Rectal foreign bodies can be really embarrassing, so we just want to be very sensitive when we're talking to patients about if they have a rectal foreign body in there. And we also want to be really aware that sometimes this can be involuntary. So patients may, someone else may have inserted the rectal foreign body into a patient. We want to be, really aware and really sensitive of those kinds of concerns that may occur. Here is a way to, if you're trying to get a rectal foreign body out of the rectum, what you can do is, this is an example of one way you can do to get out. This is a Foley catheter that you basically insert past the foreign body and then inflate the balloon so that you have something that has like expanded past the foreign body. So you want to insert this Foley catheter all the way past the object, and then you inflate, and that gives you a little more traction and pressure to really kind of pull it out of pull the foreign body out of the rectum right there. Go all the way here, and then you can pull it all the way out there. And the sedation for this, you can do a perianal block, you can do a procedural sedation to help patients kind of relax and make it through this type of procedure. So we're going to switch topics. It's a little bit of a different topic right now, but we just want to cover a little bit of this called geriatric abdominal pain. So basically, this is like abdominal pain in older adults, patients who are older than the age of like 65 or 70. And the reasons why these patients have special considerations are that older adults may not always mount a fever when they're ill. Just because they're older. They have sometimes medicines such as beta blockers or calcium channel blockers can hide any sense of tachycardia that are going on. And so patients who are ill may not have a fever, or they may be septic, but they may not have a fever, and they may not have any signs of tachycardia because of their beta blockers or their calcium channel blockers. Peritoneal signs are less common, and the abdominal exam tends to be less focal in older adults because as people age, the nerve distribution changes a little bit. And so because of all these reasons, we really want to have a very low threshold for a CT scan of the abdomen. So some of the other kind of common geriatric abdominal pains, like for example, appendicitis. This is one of the most commonly missed diagnoses in older adults. And you want to make sure that it doesn't always necessarily present with just right lower quadrant pain. It can sometimes present with any kind of abdominal pain. And for these patients, we want to get a CT scan with contrast and a surgery consult. Another condition that's very commonly missed in older patients include abdominal aortic aneurysm. So an aneurysm is most commonly mistaken for a renal colic or kind of kidney stones. And this can present exactly like a kidney stone with some flank pain and some hematuria. And when this happens, we want to get a CT scan with contrast to see if there's an abdominal aortic aneurysm there or not. And want to get a vascular surgery consult if we do see an abdominal aortic aneurysm. And this is, any kind of, especially in patients who have never had renal stones before, flank pain and hematuria, you should definitely consider a AAA in addition to kidney stones, especially if they've never had anything, any kind of history of kidney stones before. Mesenteric ischemia, which is classically described as pain out of proportion to the exam. And this includes kind of commonly mistaken for viral gastroenteritis. So, it can present with nausea, vomiting, and diarrhea. And it's very easy to call this, viral gastro and miss a mesenteric ischemia. You can see an elevated lactate and an elevated lipase in these patients. And some of the significant risk factors for having mesenteric ischemia includes atrial fibrillation or ventricular aneurysm after myocardial infarction. And the diagnosis for these patients is a CTA of the abdomen. And the last one, which is not necessarily an emergency unless it's perforated, is a peptic ulcer disease. So this can occur especially when patients get old and they have arthritis and they're starting to have chronic pain, that they start needing to require ibuprofen. And this in a perforated peptic ulcer disease may not show any peritoneal signs. And the CT of the abdomen will show free air. So you can do an X-ray as well if you're very concerned about free air, but a CT scan is really the best option to look for any kind of free air that's going on. That's about it for us today. What questions can we answer, or what kind of topics do we want to talk about?
To the WhatsApp. So
let me open WhatsApp actually.
Most of them we do the CT scan, and we reconview it with 3D, and we can see it very clearly what in the rectal. You see that?
I do see that.
What is it? This is the cup. This is a very big cup. This is 10.
The cup inside the rectum?
Yeah.
How did you remove it?
Open the chest open operation. The surgeon open it and take it out by the prawns. They cannot endoscopy because the cup is just it's just the situation, you cannot pull it out. If you try to pull it out, the rectum is explored. It's so hard. So the patient just have like something on high, and he just masturbate with the cup, and and not good at all. So the cup just go directly to the rectum and stuck in there. And we try to do something like endoscopy, but it's not work. So they just operate. They just go into they just open it and check it out, and to shutter the rectum and make the hole on the abdomen. And after that, maybe 1 month after that, we just close the hole already. So interesting, right? So in Chile, we have a lot of foreign in the rectum like that. When the people on high, or just that they use cocaine or something like that, they just do whatever they want. Eat the watermelon, just like a bowl, something like everything. So to put it into the rectum, and if it's small, you can easily take it out, but this is a very big one, 10 centimeter, so it's a little bit big. So this our experience about that in Chile.
That is very, very interesting. This sounds like a very relevant topic right now in terms of like something that we all see kind of very frequently. I had one case last night too when I was working that someone swallowed a bunch of razor blades, and GI had to come take it out. So foreign bodies are actually very common when people swallow it or they kind of insert it up their rectum. There's a lot of different foreign bodies that happen.
Right.
Yeah. What other questions can we answer? Any other interesting cases anyone wants to share? Any other questions they want to ask?
Yeah, I wonder, it is very big. So it's like Dr. Dai said, is 10 centimeters, 10 in centimeters. So it is quite big. I wonder how could they put the glass into the rectum?
Oh, how they? I think if you push on it, it usually the rectum is a lot of soft tissue there, and it's very kind of expandable. So basically, when you push on it, it usually goes in.
Oh.
It's interesting how the rectum can expand to accommodate a lot of different kind of large objects there.
Yeah. And so talking about mesenteric ischemia, I found this topic is really interesting. And but the patient with this condition may have a really tragic outcome. Like a lot of patient was misdiagnosed with viral gastroenteritis, and we saw quite a number of patients that the patient had diarrhea and vomiting, so they were diagnosed with gastroenteritis, but they end up having mesenteric ischemia, and but so because of the patient was transferred from other hospital in a severe condition like metabolic acidosis or shock and even cardiac arrest. So I found that your slide about mesenteric ischemia is very interesting, informative.
Yeah, so definitely it is very hard to catch mesenteric ischemia, right? Because a lot of times, for belly pain, we do, CT scans with IV contrast, but we don't do the CTA. And the CTA is what we really need to see for mesenteric ischemia. Hannah, do you have any suggestions about what's a good way to catch mesenteric ischemia? It sounds like you've seen a lot already, but any ideas about what's a good way to kind of, to kind of be aware of mesenteric ischemia?
Actually, this is the questions I want to ask you and everyone.
Yes. Yeah. So it's challenging, right? Because I think it's really hard to kind of see. I think if we, especially for older people, if we just want to make sure we're very aware, of when they come in, that we consider kind of other things. That can lead to that, right? So, any kind of abdominal pain, we want to see, elevated lactic is a good reason. And they have a lot of risk factors like atrial fibrillation, especially if they're not on blood thinners or atrial fibrillation or like any prior kind of heart attack, and they're having severe abdominal pain. Those are all reasons for mesenteric ischemia. Kind of like you're saying, Hannah, like there can be a lot of complications from this. So we want to make sure we're able to catch these conditions, because it can lead to like bowel, like sometimes they end up taking out part of the bowel because it's dead already. We want to make sure we were able to be aware of this, so that there's it's not a very common type of condition, but something we definitely want to be aware of as we're kind of going through seeing our patients, especially patients who are older adults.
Yep. And thanks for your opinion. And we can consider blastate in the ABG, but do you know, because sometimes I have patients with ischemia, mesenteric ischemia, but blastate, in some cases the level of blastate is very high, but in some cases it's just normal, but the injury, the lesion of the gut during operation is very severe. But I don't understand. Sometimes the lactate level is quite low, like in normal range.
I think it depends, right? So again, there's not one, except for the CTA, which tells is there a mesenteric ischemia or not. There's not a one lab test that can unfortunately tell us about mesenteric ischemia. Unfortunately, some of these can be very challenging. I think if you're sometimes essentially the lactic is basically like an amount of whether or not the patient how much of the bowel is dying. And so it can really depend on everyone too. Like some patients don't produce a lot of lactic acid to begin with, and that's maybe the lactic is already a little bit low. But again, there's not one test that can tell us everything. And so like we were saying, you've seen cases where someone has a lot of mesenteric ischemia, but like a normal lactate or very minimally elevated lactate. And if that's the case, we just want to again make sure we have a very broad differential when we're kind of seeing patients and kind of considering a lot of the different differential diagnoses that we can see when we're seeing a patient with older with geriatric abdominal pain.
Yeah. Thank you. And one thing that I found quite challenging when or the CT scan for those for this kind of patient, because they normally have acute kidney injury, and sometimes the kidney function is too low that we kind of hesitate to do CT with contrast enhanced.
Yeah.
And yeah.
So that's a very good point. That's a very, very good question. And I think so we've actually been struggling a lot with that here, in the US as well, whether or not if a patient has kidney injury, if you should give them contrast or not. A lot. So I know that there's a lot of teaching about, how contrast kind of injures the kidneys. Some, and this is kind of pretty new, some doctors are starting to move away from that now a little bit. Especially as we're kind of moving forward, it depends on which doctor you ask. Some doctors don't even think that contrast actually, causes nephropathy. And it was a completely, the study wasn't very well done. Generally, the idea is if you're concerned, like kidney injury is a kind of a long-term, like chronic kidney disease is is a chronic condition. And mesenteric ischemia is an acute condition. So if if based on your history and your exam and your lab work, you're really concerned about acute mesenteric ischemia, I would probably say go ahead and do the scan, even if the kidney function isn't the best. If you're concerned about mesenteric ischemia, that's generally the guideline. If we're concerned about something that's emergent or acute, we go ahead and do the scan that's necessary to see that, and we can either dialyze them or give them more fluid to kind of help wash out the chronic kidney disease there. But that's kind of what we've been doing in the US, but I'm curious if anyone else has kind of any other experience handling that, because that is a very good question, Hannah. CTAs can there's a lot of contrast, and we're seeing a lot of older patients with chronic kidney disease. Any other ideas or experiences, or any other anything else someone wants to share? Questions or experiences or things you've seen before?
Yeah, I want to share a little bit that
Yeah.
I could read your slide about geriatric abdominal pain is really helpful. Yeah, because I could see that you summary the case that we easily miss. And about the aortic, also the AAA. So have you seen any case with AA that lead to hematuria?
I haven't personally seen a lot of cases of AAA before. I mean, I saw one probably a couple of days ago, but they're not very common kind of conditions. It's more that like AAA, it's been known to lead to hematuria, but I haven't personally kind of seen it in my own practice. And a lot of times we know that they have hematuria as well. We just sometimes some patients may come in altered or confused and not able to give us a whole history, and that's why we just want to keep a very kind of broad differential that it could be a AAA. So a lot of times for kidney stones in younger patients, if they're in their 20s or their 30s or even their 40s, we don't always necessarily need to do a CT scan, but we can. But I think the point is, like, as patients get older, into their 50s and their 60s, even if they're saying they have kidney stone, a CT scan is definitely worthwhile, especially, you know, as they get older and older. And that way we, you know, we try not to miss something that's going on there. But I haven't personally seen a lot of cases. I haven't personally seen a lot of AAA cases myself because it's not very, very common. And the aneurysm basically needs to start leaking before you see the hematuria. So like a stable abdominal aortic aneurysm probably wouldn't lead to a hematuria. It usually needs to be there has to be some kind of leakage there that before it leads to that.
Thank you. I just want to share a little bit about my case. Actually, I have a case that a male and about 60 years old. He's come with us with a really sudden abdominal pain, but at the lower right quadrant. At first, we think that the patient has an appendicitis, but then it comes out to be an aneurysm in a common iliac artery. So it's really because the pain, he said clearly that it's spread to the back. So, but it's really rare that he just only has aneurysm of the common iliac, not the aortic. Because at first, if he talked to me, if he tell me that he has a pain in the middle, like yeah, so I could guess that he has the AA because he told me clearly that it's red to the back.
Yeah.
You know, and then he's then he's go to shock. We have to give him about 3 units of blood before leading urgency to the surgery. But finally, he's the outcome is good after weeks in the ICU. But now he could discharge to the hospital with no complication.
Good. I'm so happy to hear that. So you're saying it was red in the back, like he had erythema? Is that what you're saying, or it was like it was trapped radiating to the back?
Radiating to the back, but he has the peritoneum size when I do the examination. But you know, it's like it's really quick. I just see the patient with the blood pressure is still stable when he was lie down, but then just about 30 minutes or nearly 1 hour ago, he go into a shock.
Oh wow!
Yeah.
From all the bleeding, it sounds like.
But he has he has symptom before, like he has like posture hypertension, but at that time I can't think about that disease, so I just think about appendicitis. I give him the ultrasound, but then so yeah, but I so released that the patient is that can be good. You know, when the doctor do the ultrasound, they called me and said that he has a hematoma inside the abdominal.
Yeah. Interesting. That's a very interesting case, and that sounds like a lot of really good work on your end too, where you're able to, there's a very complicated patient. It sounds like you did a really good. It sounds like you did a really good job, like making sure that the patient got what they needed, got them to the ICU, and it looks like the patient ended up doing pretty well, even though it could have gone pretty bad. But it looks like you took really good care of this patient.
Yeah, so just want to share that it's not only on the aneurysm in the aortic, but also in the common iliac, and the patient had a pain on the right side.
Yeah, absolutely.
Okay.
Excellent. That's a very, very good point, that it's not just the aortic, it sometimes go down the other vessels as well. So thank you for sharing that. That's a really, really good point.
So can I? So you will send your slide to
I will. Yeah, I'll send out the slides. Once we're done here, I'll definitely send the slides out for everyone to take a look at. And feel free to remind me if I forget to as well. You can always send me a WhatsApp message and I'll remember to do that. Any other things anyone wants to share?
Yeah, your presentation is very informative.
Thank you,
Yeah,
I appreciate it.
and I just want to share, some cases with mesenteric ischemia, and there because Dr. Ying told us about a rupturous aneurysm, aortic aneurysm. So I just want to share. There is one case that I met before. Like the patient admitted to the ED because of abdominal pain, and so we when we do a CT scan and found out that patient have aortic aneurysm, but he also have mesenteric ischemia because of dissection, and so that's why he admitted to the ED because of because size of mesenteric ischemia first, and then we found out that the patient the root cause is aortic aneurysm. Yeah, it is a challenging case.
So they have both an aortic dissection and mesenteric ischemia. Is that what you're saying?
Yep. So like the patient have aortic dissection, and it's spread to the mesenteric artery, and so the patient ended up having abdominal pains and mesenteric ischemia.
Wow. And was that your patient too, Hannah?
Like patients in the ED that
I see.
we met, like we saw quite a lot of patients with triple eight.
Yeah.
And yeah, some, but recently I don't know why. Like recently we have quite a lot of patients with aortic aneurysm in thoracic aortic aneurysm, like Stanford A.
Yeah.
And I don't know why, but yeah.
That's very interesting, and that's a very good catch, right? Because those are two very hard things to catch, right? The aortic dissections and mesenteric ischemia, they're not very common conditions and they're not easy to catch. That's a very good catch that you found both of those, kind of uncommon conditions in just one patient. That's a very good catch there.
And if the patient have like bleeding from ruptures, or like in the late phase of ischemia, the patient might have peritonitis, and then they may have peritoneal size.
Yeah, definitely.
Yeah, so I normally I thought that mesenteric ischemia, like the patient will have pain out of proportion, and when we examine the patient, there is no peritoneal, like no rigidity. Yeah, but in some cases that the patient came to us like in many days after they have symptoms. So like how to say, they have a necrosis of the intestine, so they have a peritoneal side. So and we found that the abdomen is like very rigid, like the patient have perforations of stomach.
Wow.
But actually they have mesenteric ischemia. And yeah, and those and that patient also misdiagnosed with gastroenteritis in the previous hospital. Yeah. So I that's when when you talk about the misdiagnosis,
Yeah.
gastroenteritis. Yeah, I found that it's a very how to say a very valuable valuable experience
Yeah.
that we should keep in mind.
Yeah, definitely. I definitely agree. You know, viral gastroenteritis is it's very easy to, you know, think someone has viral gastroenteritis and it ends up being something else. Anyone else want to share anything? Those are really good cases. I really appreciate everyone sharing. Any other interesting cases or experience or questions anyone wants to share? If not, we can, I know we're almost out of time, so I hope everyone has, we don't have a lecture the next 2 weeks for TET, so I hope everyone has a good time celebrating. And I'll be visiting Ho Chi Minh City soon. I sent Dai all my dates, but I'll probably be the week of the 13th through the 17th in February. So that week we'll probably do an in-person lecture, just like you did with Shirley last time in October when she was here. So we'll be doing that as well, but I'll send out all the information to Dai and he can kind of help coordinate that as well. But I hope everyone has a great TET and a great Lunar New Year. And again, we're not doing the lecture next week or the week after. So we have 2 weeks off before we start everything again.
Thank you.
Yeah. Thank you so much.
Thank you for coming.
Yeah.
And we'll talk soon, okay? We'll talk in February. And I'll be visiting in the middle of February as well. So I'd love to see everyone there.
Yeah, love to see you.
Okay. Have a happy TET, happy New Year.
Yeah, thanks so much. And bye-bye.
Happy
Everyone.
holidays.
Happy TET, happy Lunar New Year.